Okay, so we're going to start talking about pain and pain control systems. This will continue on into Chapter 8 when we will start to talk about the concept of pain as disease, chronic pain as disease, and pain matrix dysfunction. There are a lot of really interesting new theories on pain as disease, and we will be talking about some of those. But first, we're just going to talk about pain and what is pain. So, pain is often associated with tissue damage or potential tissue damage. So it can be experienced independently of tissue damage. So tissue damage isn't necessary in order to experience pain. The nociceptors signal injury, but nociceptor activity in and of itself isn't causing the pain. Pain is the perception of those signals in your brain. So we talked about a little bit earlier in Chapter 6 how the affective part of pain, where your emotions and your experiences and your reaction to that nociceptor signal is a big controller of that pain. Okay, so there's a little video, it's about 2 minutes long, that's called Pain is in the Brain, which is kind of interesting if you want to watch that. And it's just sort of we're paving the road for that idea of that we have a lot of power ourselves to control our pain, because a lot of it has to do with how we're perceiving it, our cultural and individual expectations of pain, our experience with pain, our emotional state, our physical state, or the state of our immune system. There is a lot that goes into the pain experience. So it's not just those nociceptors, it's not just tissue damage or potential tissue damage. So listen to that phrase, potential tissue damage. That means nothing's happened yet, but we're experiencing pain. So that just tells you our brain is a powerful driver in the whole pain cycle and what's going on with it. So it's pretty interesting. So when we talk about pain from muscles and joints, signals that are interpreted as both fast and slow pain, so remember that A delta pain and the that's tightly localized and fast, and that aching slow pain, which goes in the divergent pathways and is more diffuse. Both of those can occur with musculoskeletal injuries. So when tissue is injury or ischemic, meaning deprived of oxygen, biochemicals that stimulate nociceptors are released. So, and we'll talk a little bit more about those biochemicals. Nociceptors that are excessively reactive to stimuli are called peripheral sensitization. So we have those little biochemicals that stimulate those nociceptors. If you're experiencing that all the time, your nociceptors can be oversensitive, and so it takes less stimulus in order to create an action potential in those nociceptors. So sensitized neurons can fire in response to normally innocuous stimuli with slight movements, and they fire spontaneously sometimes even without any stimulus. So if the neurons are oversensitized, you can get a pain response with something that normally wouldn't cause pain. So I sort of think of it as the car alarm. Somebody has the car alarm that's way too sensitive, and a leaf blows by and it sets off the alarm. But normally what you want your car alarm to do is people can walk by the car and normal things can happen, but if somebody tries to break into the car, you get more stimulus, then the car alarm goes off. So those oversensitized nerves are like the oversensitive car alarm, which goes off when a leaf blows by. And that's really annoying, because you're trying to sleep and your neighbor's car alarm is going off just because a leaf blew by. Same thing with pain. You have those ultra-sensitive, those peripherally sensitized nociceptors, and you're getting pain from you're lying in bed and the blankets are on your painful part. So you're getting something that wouldn't normally be painful. It's normally innocuous, but now it's causing you a lot of pain. Okay, so unlike superficial pain, which is what we just talked about, deep pain usually occurs after the tissue has been damaged. So that one actually is resulting from tissue damage. So the function of deep pain, just the biological function, might be to encourage you to rest the damaged tissue. So a lot of times after a lower extremity injury, you get pain with weight bearing. And it's we refer to it as an antalgic gait pattern. Algia is the Greek word for pain. Antalgic, so it's a pain-avoiding gait, basically. So the modified gait is characterized by that shortened stance phase on the affected side. So we're getting off that foot really quickly, and that's probably the function of that is to encourage us to rest that damaged tissue. Makes sense, right? So a lot of our reactions, they're survival mechanisms. You know, if you're a caveman and you get injured out there, you're not going to be going to the doctor, and they're not going to be giving you pain meds or setting your bone or anything like that. So you better have some survival mechanisms in place, or you're going to be a dead caveman. So it's the A, delta, and C fibers transmitting pain from the muscles and joints. So a lot of times when you get the oversensitized ones that are excessively reactive, a lot of times it's the C fibers. The deep pain is the tissue damage that is encouraging rest for those damaged tissues. There's a 12-minute video that's an introduction to nociceptors, optional whether you want to watch that. When you we're going to look at the homunculus again. So you notice that some of the areas are disproportionately represented in the primary sensory cortex, hands, face, etc. Probably if you got I'll use the paper cut example. If you got a paper cut on your knee, it probably would not be as painful as one on your finger, because you don't have the same representation in the sensory cortex on your thumb versus on your knee. So there's less area being represented, less sensation. So we have increased sensation in the hands and the face. So if you want to see a video demonstration of antalgic gait, I'm sure we've all seen it, but it's nice to look at the video, sort of get that into your head. That's something that you'll often note in the objective portion of your SOAP note. You will note that the person has an antalgic gait, and you will usually say they have an antalgic gait with shortened stance on the left side, or whichever side they have the shortened stance on. This is also known as limping. So we've all done it, we've all seen it. So I just think this is kind of funny. The U.S. Marine Corps, their definition of pain is weakness leaving the body. That won't be on the test. I just thought that was weird, and I saw this tattoo, picture of the tattoo, and I thought, that's creepy. So pain isn't weakness leaving the body. Pain is actually a brain response to some neural sensations that you're getting. Okay. So we're going to talk about some different kinds of pain, one of them being referred pain. So referred pain is pain that is perceived as coming from a site distinct from the actual site of origin. So wherever our tissue damage is or a problem is, we are perceiving pain as coming from another area. Usually referred pain we're talking about, it's referring from a visceral organ to the skin in the same sensory dermatome. So pain fibers from organs and pain fibers from skin converge into collateral branches in the spinal cord or thalamus, and the dorsal root neuron innervates skin and the viscera, and the signal is misinterpreted as coming from the skin. So there's a little chart. And that's just a theory. They really do not know exactly what causes that referred pain, but you get pretty accurate representations of skin of the dermatome areas that correspond to different organs. So there's this diagram in the book which shows the pain referral systems. So a lot of times when somebody says, I have pain right in, if we look at area number 4, that's sort of on the right side, just under your ribs, that could be referred from the liver, Gallbladder pain, on the other hand, tends to be referred to the back, the posterior side of the trunk. And even though the gallbladder and liver are physically right in the same area, they refer pain to different areas because the pain fibers from the organs converge with collateral branches of pain fibers from the skin in different areas. So that's just sort of, you should know the definition of referred pain. There's a short little video about referred pain. You should know that, and you should just be aware of when somebody reports pain in a certain area, it might not necessarily be coming from that area. So that's kind of an important distinction. So just to review, referred pain is pain that's perceived as coming from a site distinct from the actual site of origin. And so that's the theory. The convergence theory is kind of the current theory on referred pain. Who knows if they'll come up with something different later. So we're going to start to talk about the pain matrix. So the pain matrix is a new concept, but the word pain matrix, or the phrase, it's brain structures that process and regulate pain information, and they're capable of creating pain perception even in the absence of nociceptive input. So it includes parts of our brainstem, the amygdala, which is that emotional brain, the hypothalamus, the thalamus, and areas of the cerebral cortex. So the pain matrix, even though it processes actual somatosensory nociceptive input that's coming in and creates our pain perception, it is also capable of creating that pain perception in the absence of nociceptive input. So that's pretty big. So you could be having pain even though nothing's happening. And in some chronic pain syndromes, for example, fibromyalgia, that can be what's happening. You're perceiving pain even when you don't have any nociceptive input. And then there's also some neuropathic pain syndromes, which we'll talk about. So there's this little graphic in the book that sort of demonstrates, it represents the pain matrix. So there are a lot of signals. The little red arrows or pink arrows are the information that's going up from the spinal cord to the brain. The black and green arrows are information that's coming from the brain back to the body. We will talk about the concept of anti-nociception. So that's anti-pain, and pro-nociception, so pro-pain, things that are decreasing pain and things that are increasing pain. So in this little diagram, the black arrows indicate anti-nociception, so those are the pain control systems that are descending from the brain. And the green arrows are pro-nociception, so those are the pain-making systems that are descending from the brain. So those can be some of those emotional, stress-related, memory-related, immune system-related, things coming from our hypothalamus, that are causing pain even though we don't have nociceptor input. So the experience of pain is strongly linked to emotional, behavioral, and cognitive phenomenon. It's not just a physical phenomenon. That's why we can't invent a painometer. Like we have a thermometer we can put on somebody and tell what their body temperature is. We have the sphygmomanometer, so we can take their blood pressure. We have a lot of things we can take objective measurements. Pain is a subjective measurement. When we ask people, well, what's your pain from 1 to 10? We're getting a subjective measurement of pain because it is not a physical phenomenon that we can measure. We will probably not in our lifetimes ever have a painometer where we can put a sensor on somebody and say, hey, you're having 6 out of 10 pain. So it's strongly linked to those emotional and behavioral cognitive phenomenon. So understanding pain requires that we consider the discriminative pain, motivational and affective components, and the cognitive and evaluative components. So the emotional and cognitive and behavioral things can strongly affect pain. And so when we talk about discriminative, it's being able to localize the site, timing, and intensity of tissue damage or potential tissue damage. So those are the things that we're getting from the somatosensory system, but then we also, and that's the pink arrows in the pain matrix chart, the motivational, affective, and cognitive evaluative components are the green and black arrows that are coming down. So there's a lot that goes into pain. It's not just a physical perception. So the motivational affective aspect is the effects of the pain experience on emotions and behavior, arousal and avoidance behavior. So a lot of the things like the antalgic gait cycle is an avoidance behavior. The cognitive evaluative aspect refers to the meaning that the person ascribes to pain. So there's a really interesting continuing ed program that's done by a PT in Seattle named Adrian Lowe, and it's called the Explain Pain program. It's a patient education program, and he talks about this the meaning that a person ascribes to pain, and he talks about like certain sort of reactions that you have. So like if we're as therapists and people that work with us all the time and healthcare professionals, we hear bulging disc and we go, big deal, everybody's got bulging discs, and it doesn't freak us out. Or we hear degenerative disc disease or bone on bone. That's the one I hate, that orthopedic surgeons are always saying to people, oh, well, your knee is bone on bone. Well, for us, we hear that all the time, and we know that means osteoarthritis. For them, they think, oh my God, no wonder my knee hurts so much. And it seems they can almost catastrophize their pain, and it can actually make them hurt more. Their reaction to those phrases and diagnoses that sound catastrophic to them can actually make them hurt more because of their the meaning that they ascribe to that phrase and that pain. So the cognitive and emotional aspects of our pain are a huge, big deal. Okay, so there's a little chart that sort of shows where the sensory aspects function, where the emotional and motivational aspects function, and where the cognitive aspects function. And I really don't expect you to know this, but just to know that pain is not coming from an individual area. It's not coming from the somatosensory system. It's not coming from the emotional system or the cognitive system. It's everything interacting together. So it's kind of neat. So we're going to start talking a little bit about pain theory now. And I know that Brenda has gone over this a little bit with you in modalities class when we're talking about counter-irritant theory and things that are things that we are using to help control pain. So we're going to have to start talking about pain control systems and our endogenous pain control systems and how pain is controlled in the body. So just as a review of what we just talked about with pain matrix, the brain structures that process and regulate pain information are capable of creating pain perception even in the absence of nociceptive input, including parts of the brainstem, amygdala, hypothalamus, thalamus, and areas of the cerebral cortex. So if the doctor says to you, you've got degenerative disc disease, and you've never heard that before, and it sounds horrible, that can make you hurt worse. Just hearing that and having an emotional response to it. So it's the experience of pain is strongly linked to emotional, behavioral, and cognitive phenomenon. So the reaction that you have to nociceptive signals, so your experience and your pain, the pain matrix generates a top-down response that regulates your ascending pain signals. So by the top-down response, we mean that the pain's not coming from the sensory information and the nociceptive stimulation, it's coming from the brain. And that it's regulating those ascending pain signals, which are coming from the somatosensory system. And so what's coming from the brain can either amplify those nociceptive signals or it can suppress them. So in that pain matrix graphic, the black arrows were suppressing the pain, and the green arrows, and those were all top-down responses. The green arrows were amplifying the pain. So we talk about things, top-down inhibition of pain signals is anti-nociception. So nociception is that pain signal, and anti is against it. So it's the things, the responses from your brain that are causing you to suppress nociceptive signals. The pain matrix determines whether the ascending nociceptive signals are going to be normal, whether they're going to be suppressed, or whether they're going to be sensitized or reorganized. So pro-nociception, it's the biological amplification of pain signals. So that can be caused by your emotional response. It can be caused by that. You can get an emotional response from that catastrophization that I talked about, where you get a diagnosis that sounds horrible to you. It can make you feel worse. It can amplify your pain signals. So we're going to talk more now about anti-nociception systems in our body, and we have physiological models for each of those. So I'm going to wrap up this section, and in the next section we'll be talking about those anti-nociception models.